Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Today, we dive deep into one of the most clinically relevant topics for anesthesiologists and intensivists, antibiotics. 感谢您今天收看麻醉与微手术期医学频道。今天我们将深入探讨麻醉医师和重症监护医师最关注的临床主题之一——抗生素。आज Anesthesia और Perioperative Medicine channel पर हमारे साथ जुड़ने के लिए धन्यवाद। आज हम anesthesiologist और intensivists के लिए सबसे चिकित्सीय रूप से प्रासंगिक विषयों में से एक antibiotics पर गहराई से चर्चा करेंगे. All right, welcome everyone. I am absolutely thrilled to be hosting this academic refresher course today. We are tackling a topic that literally saves lives in our operating rooms and ICUs every single day, but also brings some of our biggest clinical headaches. We're talking about antibiotics. As anesthesiologists, we push these meds constantly, but today we're going way beyond the basics. We are going to completely deconstruct these drugs from their molecular origins to the severe, hidden adverse effects that we might be overlooking, and finally the terrifying reality of antimicrobial resistance that we face on the front lines. So grab your coffee, get comfortable, and let's master this together.
Here is a quick look at our game plan for today. Section 1 covers the origins and classifications. Section 2 is a deep dive into the mechanisms of action. Section 3 hits the adverse effects and hypersensitivity reactions, and Section 4 covers the antibiotic resistance crisis.
Section 1. Origins and antibiotic classifications. To truly appreciate the weapons we use in the OR, we have to look back at where they came from. The very word antibiotic actually stems from Greek roots meaning against life, specifically the life of pathogens. The modern era of these incredible drugs really kicked off back in 1907. That's when Paul Ehrlich discovered Arsphenamine. He was looking for a magic bullet that could specifically target syphilis without killing the patient. It was a massive breakthrough. But the real game changer, the one we all know, happened in 1928, when Alexander Fleming famously left his petri dishes out and discovered penicillin. Fast forward to 1945, right at the end of World War II, and we finally achieved the mass production of penicillin. This sparked the mid-20th century golden age of antibiotics, fundamentally revolutionizing surgery. Before this, even a minor surgical incision was a roll of the dice with deadly infections.
Depending on exactly what we need clinically, we draw from three main categories, based on how the antibiotic is made. First, we have the natural antibiotics. These are the original mold and bacterial derivatives, things like early penicillins and aminoglycosides. They are literally nature's chemical warfare. Then we have the purely synthetic agents, which are 100% laboratory creations. Think of sulfonamides or nitrofurants. Finally, we have the semi-synthetic agents. This is where we take a natural molecule and heavily modify it in the lab to make it better. Maybe we broaden its spectrum or we make it resistant to the enzymes that bacteria use to fight back. Cephalosporins and methicillin are classic examples here. And while we're classifying things, it's absolutely crucial to remember the difference between narrow-spectrum and broad-spectrum agents. Narrow-spectrum drugs are our sniper rifles, hitting very specific bacterial families, while broad-spectrum drugs are our shotguns, wiping out a wide array of bugs, but taking out the patient's healthy microbiome in the process.
Now, you've definitely heard the terms bacteriostatic and bactericidal, but what actually defines that line? It's not just a guess. It comes down to hard laboratory math. Specifically, it's the ratio of the minimum bactericidal concentration, or MBC, to the minimum inhibitory concentration, the MIC. If that MBC to MIC ratio is greater than 4, the drug is considered bacteriostatic, meaning it just pauses bacterial growth and relies on the patient's immune system to clean up the mess. If the ratio is 4 or less, it's bactericidal. It actively kills the bacteria outright. But here's a pro tip for your clinical practice. These aren't rigid walls. Take linezolid, for example. It's generally classified as a bacteriostatic drug, but if you're targeting specific bugs like Streptococcus pneumoniae, it actually exhibits powerful bactericidal activity. So we always have to maintain some clinical flexibility depending on the exact pathogen we are fighting.
Section 2. Mechanisms of antibiotic action.
Let's get down to the cellular level. This is where the magic happens. First up, inhibiting cell wall synthesis. Bacteria have a high internal osmotic pressure, and without a strong wall, they literally pop. Their wall is made of a peptidoglycan layer, which is essentially a chain-link fence made of alternating NAM and NAG sugar molecules. Our heavy hitters, the beta-lactams, like the penicillins and cephalosporins we push every day, bind directly to penicillin-binding proteins, or PBPs. These PBPs are the mason workers that cross-link the fence. By binding to them,
Beta-lactams fatally halt the construction. On the other hand, glycopeptides like vancomycin use a different strategy. They physically cap the D-alanine tails of the building blocks, blocking the cross-linking process entirely. Either way, the cell wall fails, and the bacteria is destroyed.
Next, let's look at how we can disrupt bacterial DNA replication. It's a beautifully complex process. First, DNA helicase unzips the double helix. Then, DNA polymerase comes in to copy the strands. But unzipping DNA creates immense mechanical tension downstream. Imagine pulling apart a twisted phone cord. To prevent the DNA from snapping, bacteria use enzymes called DNA gyrase and topoisomerase IV to carefully cut, untangle, and reseal the strands. Enter the fluoroquinolones. These drugs are brilliant. They sneak in and stabilize the enzyme DNA complex right after the DNA is cut, but before it can be resealed. They literally jam the machinery. The result? Catastrophic, irreversible double-strand DNA breaks. The bacterial cell's entire genetic code shatters, leading to rapid cell death.
We can also target the bacterial factories, the ribosomes. Bacterial ribosomes are made of a small 30S subunit and a large 50S subunit. Because these are structurally different from human ribosomes, we can exploit them. Let's look at the 30S inhibitors first. Aminoglycosides bind to the 16S RNA on the 30S subunit, causing the bacteria to misread the mRNA, producing junk proteins. Tetracyclines also hit the 30S subunit, but they physically block the A site, preventing tRNA from even docking. Now for the 50S inhibitors. Macrolides latch onto the 50S subunit and completely freeze the growing polypeptide chain, clogging the exit tunnel. Chloramphenicol directly inhibits peptidyl transferase, the enzyme that actually forms the peptide bonds. And oxazolidinones, like linazol, stop the 30S and 50S from even joining together to form the initiation complex. It's a total factory shutdown.
Alternatively, we can selectively starve the bacteria. Unlike humans, who get folic acid from our diets, bacteria have to synthesize their own folic acid from scratch to make DNA. We can hit this pathway with a 1-2 punch. Sulfonamides act as a competitive inhibitor for the enzyme dihydropteroate synthase in the very first step of the pathway. Then, trimethoprim comes in and blocks the very next step by inhibiting dihydrofolate reductase. When we combine these two, which we often do with TMP-SMX, we create a synergistic, sequential blockade that completely shuts down the bacteria's folic acid production. No folic acid means no nucleotides, which means no DNA. It's an elegant, highly targeted metabolic takedown.
But as clinicians, we have to zoom out for a second. Human medicine is just a fraction of the global antibiotics story. We are pouring thousands of tons of these exact same drugs into animal husbandry, agriculture, and aquaculture. In farming, they are frequently used not just for treating sick animals, but as routine growth promoters. In aquaculture, it's even wilder. Massive amounts of antibiotics are dumped directly into the water to treat fish diseases, and up to 75% of those active compounds pass right through the fish and remain in the aquatic environment. This massive, unchecked environmental exposure is a colossal driver of the resistance mechanisms we are going to talk about shortly. It's a true One Health problem.
Section 3. Adverse effects and hypersensitivity in practice.
We know these mechanisms are incredibly potent, but they inevitably cause collateral damage in our patients. We generally divide adverse drug reactions into two main buckets. Type A reactions are predictable pharmacological effects that are dose-dependent, things like GI toxicity. Type B reactions are the idiosyncratic, immune-mediated responses, like allergies, which are totally independent of the dose. In clinical practice, we categorize the frequency of these events using CIOMS criteria, ranging from very common, meaning more than 1 in 10 patients, down to very rare, which is less than 1 in 10,000 patients. When we hit a patient with broad-spectrum antibiotics, we absolutely devastate their gut microbiome. This very commonly leads to nausea and diarrhea. But in our complex perioperative and ICU patients, it paves the way for dangerous, opportunistic infections. Think about secondary Candida overgrowth, especially in our poorly controlled diabetics or the dreaded Clostridium difficile infections. And honestly, there are top overlooked adverse effects we miss all the time, like drug-induced cytopenias, neurotoxicity from high-dose beta-lactams and renal failure, and severe electrolyte derangements.
Speaking of C. diff, it's absolutely vital to understand the relative risks associated with different antibiotic classes. When we look at the data for high-risk C. diff triggers, the list is staggering. We're talking about ampicillin, amoxicillin, clindamycin, third-generation cephalosporins, and fluoroquinolones. What should really give us pause here is that these are the exact drugs we use routinely for surgical prophylaxis and empiric ICU therapy.
The relative risk of triggering a severe, life-threatening C. diff colitis skyrockets when we use these specific classes. We have to constantly weigh this risk when we are writing those post-op orders.
Now, let's talk about the red flags on the pre-op chart. Hypersensitivity. The prevalence of documented antibiotic allergies is huge, around 8.8% of inpatients and over 11% in internal medicine outpatients. The top 5 classes implicated are penicillins, taking a massive 42% share, followed by sulfonamides at 25%, then fluoroquinolones, tetracyclines, and macrolides. The reactions range from urticaria and skin manifestations, making up about 21.8%, to severe GI symptoms, and about 2.5% progress to full-blown anaphylaxis. But here is a massive clinical pearl for anesthesiologists, the 90% rule. Research consistently shows that 90% of patients with a self-reported penicillin allergy can actually tolerate penicillins perfectly fine. Often it was just a childhood viral rash mislabeled as an allergy. To navigate this safely, we have diagnostic tools like skin prick test, specific IgE measurements, basophil activation assays, and cast ELISAs. Having a robust pre-op antibiotic allergy evaluation checklist can prevent us from unnecessarily resorting to less effective, more toxic, second-line alternative antibiotics.
We also have to be hyper-vigilant about severe, life-altering harms often flagged by FDA black box warnings. Quinolones are a prime example here. They carry severe risks of Achilles tendon rupture, an increased risk of aortic aneurysms, and irreversible peripheral neuropathy. But let's shift gears and look at the critical care perspective. In the ICU, antibiotics cause harm through mechanisms we rarely think about. There's mitochondrial toxicity because mitochondria evolved from bacteria. Antibiotics can inhibit our own cellular electron transport chains, generating massive reactive oxygen species and causing DNA damage. They cause immune cell dysfunction by impairing macrophage phagocytosis and suppressing the NLRP3 inflammasome. Because of this profound cellular harm, ICU studies comparing early versus conservative antibiotic strategies or trials looking at ventilator-associated pneumonia duration like 8-day versus 15-day courses increasingly show that shorter, highly targeted therapies actually improve mortality by minimizing these toxic off-target effects.
Section 4. The Antibiotic Resistance Crisis.
This brings us to the most terrifying clinical challenge of our generation: antibiotic resistance. The WHO predicts that by 2050, antibiotic-resistant infections could cause up to 10 million deaths annually. 10 million! The WHO has even published a priority list of resistant pathogens, the so-called escape pathogens, that urgently need new treatments. How are bacteria doing this? Well, their first defense is simply keeping the drug out of the cell. They do this by decreasing the number of porin channels on their outer membrane, essentially locking the front door. But if the drug does manage to get inside, they deploy their next weapon: efflux pumps. Bacteria can dramatically overexpress these membrane proteins, acting like cellular bouncers that physically bail the antibiotic molecules right back out to the environment before they can ever reach their intracellular targets.
If keeping the drug out doesn't work, bacteria have 2 more genius strategies. First is target modification. They literally change the locks. Remember vancomycin binding to the D-alanine residues? Resistant enterococci, like VRE, cleverly mutate that residue to D-alanyl D-lactate. Vancomycin just bounces off. We see similar target modifications with mutated penicillin-binding proteins in MRSA or modified DNA gyrase structures that make fluoroquinolones useless. The other strategy is enzymatic inactivation. Bacteria produce enzymes like beta-lactamases or aminoglycoside-modifying enzymes that actively hunt down and chop up the antibiotic molecules. And the scariest part? They share these blueprints with each other. They transfer these resistance genes through conjugation via plasmids, transformation by soaking up naked DNA from dead bacteria, or transduction via bacteriophages. This horizontal gene transfer is what creates our nightmare multi-drug resistant or MDR strains like MRSA, VRE, and ESBL-producing bacteria.
But guys, we have to look in the mirror. We have to own our part in this crisis. The data is incredibly humbling. Across human medicine, agriculture, and animal husbandry, our usage patterns are deeply flawed. In clinical practice alone, it's estimated that 30 to 60% of patients receive more antibiotics than necessary. We see it all the time: prescribing broad-spectrum agents for viral infections, continuing surgical prophylaxis for days instead of hours, or prescribing just in case, without waiting for cultures. This massive systemic overprescription by medical professionals provides the exact evolutionary pressure that forces bacteria to mutate and select for these extreme resistance traits. We are actively arming the enemy.
So as we wrap up this explainer, I want to leave you with a real challenge. When you head back into the operating room or the intensive care unit tomorrow, I want you to critically evaluate every single antibiotic order you write. How will you personally adapt your perioperative prescribing habits? Can you de-escalate to a narrower spectrum? Can you stop the surgical prophylaxis earlier? Can you take the time to dig into that self-reported penicillin allergy? We are the stewards of these miraculous, life-saving tools. It is entirely up to us to protect their efficacy, so that they still work for the patients who will desperately need them tomorrow. Thank you so much for joining me today, and I'll see you in the next session.